Fusion, the international science radio show.
Hi, Ian. I'm Dr Kathryn Williams. I'm an obesity specialist who works in Greater Western Sydney, also a researcher in the social determinants of health of obesity.
What is obesity? Is it just fatness?
It's a good question, actually, because I don't think anyone really knows the answer to that question. So traditionally, we have used body mass index to define obesity, and that's your weight divided by your height in meters squared. That's because at a population level, when we look at people's BMI, we know that it increases their risk for disease. But when you get down to the person, that's where the problem begins, because obviously a 20-year-old Maori man is going to be very different to your 80-year-old, I don't know, white granny. So how do we then resolve that? It is defined actually as excess adiposity, and clinical obesity is when that adiposity, so fat, can contribute to sickness and loss of function.
And it seems to be connected to a lot of health problems, not just diabetes or heart issues.
Yeah, it's an interesting one because it's not just health issues that get affected either. So did you know that your education can be affected by your level of education, your financial attainment, so you know how employable you can be in the future, and also it can affect your children. So when we're talking about health, yes, the low-hanging fruits, your type 2 diabetes, your heart disease, all that sort of stuff, kidney disease, but we're starting to think about cancers now. So all sorts of cancers like breast, colon, liver, but also some smaller ones like pancreatic and thyroid cancer even are affected. So we're starting to realise that it affects our health lots of ways, mental health as well, and just your general energy level.
It's one of those issues that's been very controversial because there's a big social stigma attached to obesity and the idea that it's a moral failing. So how does that factor into things?
Yeah, it's a funny one, isn't it? I mean, you wear your obesity on your sleeve, don't you? So you can't hide it if you had some other health issue. So, and in society, it's thought of as the last socially acceptable form of stigma, which is really unfortunate because actually it's not an even playing field. So if you put 100 different people in the same environment, some would lose weight, some would be their weight normal, and some would gain quite a lot of weight. And that's just because, one, we inherit appetite signaling and also how we anticipate and respond to food, and other things is that just that lifetime exposure of different things in our environments sets us up. So I think a good example for this is, you know, in Greater Western Sydney, in some of the suburbs that I live and work in, obesity rates are around 40% compared to your Bondis or your Campertowns where it's more like 15%. So that pretty much tells you that it's all about the postcode in my mind.
So there's so many different ways this affects you. How many people are affected? Is it a half of the population? How many people?
Yeah, so the figures are about 8 million people, Australians, living with obesity, and that's so 1 in 3 adults and 1 in 4 children. So quite significant numbers. So it almost becomes normal in some populations, but actually it is associated with health and wellbeing issues. And so we really do need to start thinking about how we're going to address it.
Well, that's a huge problem. It's so many people. And as we're saying, in society, it's considered, it's your fault. You're too poor, you've got too poor self-control, and it's considered a luxury to go on some sort of fat-reducing program rather than something you could get on Medicare.
And yet we know that you inherit obesity. So if you've got one parent with obesity, you've got 3 times increased risk of having obesity. And if you've got 2 parents, it's 10 times. So there's your genetic risk. And then, like I said, the postcode is a massive risk factor. So actually, it's very much about society's response to this condition rather than blaming the individual. So someone with very severe obesity often has a whole heap of other stuff going on as well. Often they really do need treatment and they can't afford it.
No. So we know that there's these relatively new, is it semaglutide treatments that can help people reduce their weight with injections that reduce their appetite. But they're very expensive, aren't they?
They are very expensive. So for the average person, so semaglutide is one type of these newer medications that we have. They're called GLP-1 agonists, and there are some combination drugs coming through using the GLP-1 and other factors as well. And they're really important because they talk to our brain setup and sort of dampen down some of that appetite and anticipation around food and make us feel more full, which is great when we're sitting in obesogenic environments, so environments that make us want to gain weight. But costs are between sort of $140 to $600+ a month for the average individual, which is unsustainable for most of us, let alone people who might have very severe obesity and disability and being unemployed.
And they're not a once-off they're a regular treatment that you have to keep taking, aren't they?
That's correct. So if you had type 2 diabetes or you had osteoporosis, you need treatment lifelong. And so I don't know why we think you can just apply these medications for 3 months and then be cured, because in fact, these are chronic processes and we need to treat them in the long term, which is where I guess the cost comes in. But I suppose providing you're treating someone who has a significant risk for developing other diseases, and good examples are like end-stage kidney disease where you could be on hemodialysis for life, or, chronic heart failure where you're in and out of hospital, there is actually a cost-saving argument to be made.
So we could be saving, we could be saving society money by treating this third of the population that aren't properly being treated and can't afford to get themselves treated.
I don't think it's a third of the population. So I think the fact that a third of the population is affected, I think, is a real call to arms that we need to do something about this problem from a system point of view. But there are people living with very severe obesity and or quite significant medical problems from their obesity. And those people, I think there is an argument for intervening. So if you can see someone who has obesity and has significant kidney impairment from that obesity, treating that obesity can actually prevent the progression of that disease and then them going on hemodialysis. The other sort of classic case is, the person with very severe obesity and disability, they can't work, so they're on social services for the rest of their life. Providing them with a treatment will enable them to get back to work and also allow them to be socially engaged and support their children. So I think we're missing the story. So there are some very, very unwell people with very severe obesity that really do need treatment. And I think there is an argument for subsidising for them. But I think at the other end of the spectrum, if a third of us are affected, we really need to do something about the way we're living.
It really sounds like it's one of those hidden problems that needs a lot more attention. So it's not just these new types of medications. What other treatments are there for people suffering this way?
When you have very severe obesity, you need to tackle it from multiple angles. So there's going to be hundreds of different things that have fed into where that person is at that point in time. So you have to sort of unpick what you can and try and modify what you can. So everyone knows about diet, right? It doesn't mean going on a diet. Often what we should be doing is improving nutrition. So making sure that you're eating as much from the ground or, sort of that you're cooking yourself as possible and planning ahead with those meals. So you're not just shoving it down and not tasting it. So spending time thinking about the food, eating with people, good quality food. Physical activity is your next one. So yes, you should go and join a gym if you like that sort of thing, but actually it's more about not sitting for long periods of time. So get up, walk around, don't be sedentary. And our jobs are setting us up for failure. Long commute time set us up for failure. So try and find ways to reduce that. If you can work from home for a couple of days a week, make sure you're leveraging that, going for a walk in the morning and afternoon, for example. Then you've got getting just the basics right. So getting good sleep is super important. So don't stay up at night on the phone, gaming, whatever. Just go to sleep, because it'll set you up for success. Mental health. So everyone's got stress in their life. I think stress does feed into weight gain. I think we need to identify that as an issue. But also, if you have more significant mental health like anxiety, depression, go and seek help for that, because that really will be feeding into your, poor health in other ways. Behavioural, there are specific behavioural strategies about weight loss, and psychologists can help you with that. Medications, and then down the spectrum, there is bariatric surgery. So that has the most evidence around the most sustained, significant weight reduction, but it's not fun. It's not something you'd, put your hand up for a picnic. It's actually a tool. You need to learn to work with it, and it is lifelong follow-up. And you can't do things like go out and have good drinks with your friends, big meals, forget all that, you have to rethink your life. So it's not the easy way out. And it's unfortunate that some people think that some people are cheating because they're having medications or surgery. Actually, these things, who would want them if they didn't need them, sort of things. But they are important strategies for some people.
It's such a tricky thing. We've got a society that wants to cut spending all the time, and yet this is such a big health problem for so many people, and potentially for almost anybody, because it's not just your appetite going up that can lead to obesity. There's all sorts of conditions. What other things could lead to people suffering from obesity?
Wow, that's a tricky one. I mean, it's your lifetime exposure. So anything, even if you're in utero, if your mother has, for example, diabetes or has some other exposure, you could be more prone to weight gain in your life. We also know that as a child, if you're having certain types of food, we could be, that could adjust your neurobiology to the point where your appetite is increased. So maybe our obesogenic diets in childhood are having a massive impact on our appetites in later life, for example. Other things, stress is a massive one. So a lot of the patients that I see who have very severe obesity, they've had a lifetime of adverse life events. And I'm talking about quite serious trauma, actually. And if there were ways to prevent that, that'd be the most fantastic, because you can never take that away. But we really need to be providing these people with support to work through those issues, because they are very, very serious and they can lead to quite serious mental health concerns. Pain or, other sort
sorry,
of...
Kathryn, you were cut off there and frozen.
Oh, no.
Well, oh, no. You were on a roll too. Sorry.
Where was I? So mental health is a very important thing.
Yes.
Can you cut and paste? You're good at...
Yes, I certainly will be editing. That's why I thought
Okay.
I'd better interrupt. Otherwise, I'd just leave it go and then cut it out.
Mental health is an important thing, but also physical health. So mental health, actually, if you are diagnosed with a mental health condition and you are put on certain medications, you can gain a lot of weight, and it's important to identify that early. So if you have some of those medications for schizophrenia, bipolar, any of those sort of medical conditions, there can be weight gain. So if you notice that happening, get some help early, because that can be quite devastating. Physical health, things like chronic pain and other things can really feed into that. So again, just talking to your doctor when you've got concerns, and particularly if you're seeing your weight go up, don't ignore it, ask for help then.
That's right. And look, I know that people suffering exhaustion and pain and general unwellness will sometimes eat just to try and feel better. And that's a hard sort of cycle to get out of as well.
Yeah, it is. So sometimes I wish people could have a bit of a life transplant, because to be honest with you, spending more time working than relaxing and thinking about how you're enjoying life. We're not supposed to live to work. We're supposed to work to live, but that's not an option for some people. And I feel like there is an argument to be made for improved social supports and potentially improving, people from lower socioeconomic status really do need a bit of a help, because they are set up for poor health in life because of that reason. But yes, if you have the luxury of being able to reduce your stress, so that might be just quarantining a day or two. Do you have to work full time? Could you have a day off? Could you really use that for your own well-being? Could you get into some hobbies that you're going to enjoy on the weekend rather than just sitting and watching TV? That's a really important thing to do. Yeah.
And can you tell me more about some of your work on the issue? Some of what you've been doing, because I know you're campaigning to get this recognised as a chronic illness, for example.
Yeah, so we've been collecting some data in some of the hospital-based obesity services out here in Greater Western Sydney, and using that information, I suppose, to tell people about the need. So, for example, at the Nepean Blue Mountains Family Metabolic Health Service, where some of the data has been collected, the average body mass index of people there is around 54. Half of them have highly complex multimorbidity. That means that they've got 5 or more diseases in 3 or more different body systems. There's also half of these people are unemployed. 1 in 5 are on disability support pension. Some people haven't even been able to pay for their electricity in the last 3 months. So talking to some of those factors, so talking about the severity of the obesity and how sick people can get with it, but also, how their financials are affected by this problem. The other thing we've been able to show is in that service, it is possible. It's not, while we think of obesity as primary prevention, we were able to show that if people were going to these obesity services, they have reduced risk of hospitalisation and also presenting to the emergency department. So they're obviously doing something in the acute health space as well. So obesity management is relevant in the primary prevention space, but also when you're very unwell presenting with something, because obesity is probably feeding into that condition if you have it.
And if you suffer from obesity at the moment and you go to your GP, what's the range of things that are available if you don't have a lot of financial resources?
That's a tricky one, Ian, and I think that's another space where we're trying to advocate. I think there are some trusted websites that people might want to look at first. So the Obesity Collective is a really good one. That's Australia's sort of peak advocacy body for obesity. There's also the Weight Issues Network, which is the peak consumer body for people living in a bigger body. So they have some trusted resources, and it's worth just getting familiar with those first. The next thing is, yes, going to your GP, but making sure you book the long appointment, because this isn't a quick conversation. This is a conversation that should be had over time. And if you don't get the right answers from your GP, you may want to find a GP who's got a special interest in this area. There are ways through the general practitioner to get certain plans where you'll be able to tap into other allied health. So you could ask for a mental health care plan, and you might be able to access clinical psychologists to help with some of that behaviour change and mental health concerns, and also chronic disease management plans where you could potentially see a dietitian or someone else who's able to help you work through some of that stuff. Other than that, it's just keeping regular follow-ups with your general practitioner, just working through some of the problems that you may arise. And if you do have severe obesity, I would recommend discussing a referral to, for example, a public hospital obesity service. The waiting is long, but once you're on that list, these clinics can make a very big difference.
Is the federal government at all receptive to the idea of changing obesity to be a chronic health issue that should be funded?
I think the way I think about it, we're sort of 20 years, like, how mental health is sort of, it's got a lot of awareness now. So certainly we're not doing everything we could for mental health, but actually there's a lot of awareness that it needs to be acted upon at both government levels. I think obesity is sort of 20 years behind that. We're starting to have those conversations, but we really have a lot of work to go on to make sure. There's so much misunderstanding around obesity, and there's so many emotional responses to it. So as you said, we tend to blame the individual. So why should government care about it, for example? Or if we do care about it, we should just tell people to eat less and move more. That's fine. So we need to start challenging those approaches to start with, and then telling the story about the impact of obesity on people's lives a bit more, which is what we're trying to do through the data gathering that we're doing now in advocacy. And economics is everything. So if we can get more financial modelling out there, that'll be important as well.
Is there a better way than BMI for doctors to measure how obese you are or aren't? Because sometimes you can gain weight without actually being fatter. Or sometimes you can be the same weight but fatter.
Yeah, I don't think we've got a better tool at the moment. But the thing to say is look at the person first, right? So yeah, look at the age of the person, what their physique looks like, and where they're wearing their weight as well. So obviously if it's abdominal, it's much worse than if it's sitting around the hips, for example. And then doing a full assessment. So like you said, if someone's gained 10% of their body weight as opposed to have stayed the same for 10 years and actually quite fit and healthy, you're probably more worried about the person that maybe is at a lower BMI but has gained a lot of weight and might have other things than the person who's been really steady and is otherwise healthy. So, and it's also looking at their risk as well. So if they've got a higher BMI, but they're 80 and might have competing reasons as to why they're not going to live for the next 5 years, as opposed to, say, someone who's in their teenage years who has a very strong family history of type 2 diabetes and things like that, that's the sort of person you're going to really worry about. So it's putting BMI in context. It's still a good tool. It still has value, but it's not the be all and end all. Yeah.
Is there anything I haven't asked you that you'd like to discuss?
I don't think so, Ian. I think you've asked me some very good questions. Thank you very much. I appreciate it. Working in the obesity space as a clinician has made me realise that I can't just be a doctor in this space. There are so many people that have significant impact from their obesity, and we need to start having the conversation now, because 1 in 3 people are affected, and some people are very severely affected.
Well, Dr. Kathryn Williams, thank you so much for your time.
Thank you. It was a pleasure. Thanks, Ian.
Study science, because you will find in the study of science a richer, more rewarding life.